Welcome to this session on phacoemulsification tips and tricks. So phacoemulsification is the heart of cataract surgery. We have the chairperson, Dr. Ravi Kumar Reddy, here with me. So there are 8 talks and every talk is of 7 minutes duration. So I request every speaker to restrict himself to the time allotted. So first talk is by Rajneel Bhattacharya.
Is he here?
No, sir.
No. Second talk is by G. Vishnu Teja.
Have.
He is here? Okay. He will speak on incisions and anterior segment OCT in cataract surgery.
If since one speaker is absent, you can take 1 minute extra.
Maybe he will come, sir.
No,
Thank
he
you,
already took permission.
A very good morning to one and all. I am Dr. Vishnu Teja from Modern Hospital, Nellore. Today I will be talking on incisions and ASOCT in cataract surgery. So we all know how important wound construction during cataract surgery is. So it helps us to maintain the fluid balance inside the anterior segment. It influences further steps of the surgery, and also it plays an important role in the immediate post-operative period, as the wound should be water sealed, watertight. And coming to the clear corner incisions, we all know how important they are. They should be self-sealing, and they also promote faster recovery, and they help in intraoperative wound stability and decrease the risk of bleeding due to minimal conjunctival manipulation. And when we want to do the corneal incisions, the instruments which come into place are these keratomes. So there are various types of keratomes, as we are aware of, like the bevel up, bevel down, and the bibevel types. So a study has been done by Akura et al. In 2001, where they have used different types of keratomes, and they tried to find out how the incisions are going to be, the shape of incisions are going to be when they use these keratomes in polyvinyl chloride sheets and soft polyvinyl chloride domes, and the entry and exit of these keratomes have been studied, and the outcomes have been like the bevel up keratomes have made a entry and exit in inverse V shape, and the bevel down keratomes, they have made a V-shaped incisions, and the bibevel makes a linear type. So commonly in India we use bevel up and down. So these are the keratomes, have no financial interest. These are RO sleek blades. So these are the bevel up keratome, where we can see the bevel up here, and bevel down keratomes, they have a flat surface on the upper surface, and we can see a bevel on the downside of it. So a bevel up keratome, routinely everyone makes a phaco incision with a bevel up keratome. I'll just play a video how the incision with a bevel up keratome will be. So a routine snake-wise movement and side-to-side wriggling movement is made, and in the same way in any type of cataracts when we are making it, just for a completion sake I am showing how it's going to be. And these are the post-operative pictures, like how we all see in our post-phaco cases. So post-operative day 4 in a routine phacoemulsification. So this is how the incision is going to be. With a bevel up keratome, the incision is going to be an inverse V shape, and when we compare when we study the incision with a ASOCT, this is how it's going to be. Like the roof and floor should be ideally equal in size, and there should be adequate length of the incision when we make, so that the wound will be self-sealed and it should be watertight. And it also helps us in having a anterior chamber stability. Similarly in another case, this is also a similar picture with the bevel up keratome, which we all routinely see. And coming to the bevel down keratomes, which are rarely used and they are employed in some institutes. So I'll just play how a bevel down keratome incision is going to be. So the incision is definitely going to be not smooth. There will be some resistance, but this is done as part of a pilot study when we wanted to check the incisions with bevel down keratome, and this is how it's going to be. Even the incision or the wound structure integrity is not going to be so great with a bevel down keratome. So even in a hypermature cataract, this is a side port made with a bevel down keratome. The main surgery was SACS. So I'll just show how the incision shape is going to be. This is how the incision shape going to be with a bevel down keratome. It's going to be a V shape. Entry and exit are going to be V shaped. Coming to the ASOCT with a bevel down keratome. So this is day 4 post SACS, where the bevel down keratome was used to make a side port. So here we can see how the shape is going to be a V shaped, and coming to the ASOCT of this incision with bevel down keratome, it's going to be very steep, and the roof and floor we can't make out exactly because it's going to be almost a perpendicular incision. In all these types of incisions, the incisions are intended to make a uniplanar and parallel to the iris, but in the previous one when we saw that, we understood like how it's going to be, roof and floor are equal, but here it is going to be an abrupt dip into the AC. Similarly, in another case, we can see how it's going to be. So this suggests how unstable the wound will be during the surgery, which makes it or preclude it from using in phacoemulsification. So I conclude, keratomes are very useful in making clear corneal incisions, and they fulfill the purpose. Bevel up keratomes, which we have a wide variety of companies nowadays, and they are very useful in having a very good wound construction for phacoemulsification. Whereas bevel down keratomes, they can't be employed in making phaco tunnels, but they may be very useful in entering the sclerocorneal tunnels. ASOCT definitely guides a lot in determining the wound construction and assessment. So when we see a bevel, bibevel, we can make out like it's going to be a flat incision. Towards the bevel, the incision or the entry is going to be towards the side of the bevel. I mean, in a bevel up keratome, the incision, the blade tends to go to upside, which makes it to have a inverse V shape, whereas bevel down keratome, the blade tends to go towards the bevel side, that is, it tends to dip into the AC. That's why the wound stability is very less with bevel down keratomes. Thank you very much.
Excellent presentation, Dr. Vishnu. We generally, majority of the people use bevel up.
Yes, sir.
And we have, I think, 2 points here important, that is the length of the tunnel.
Yes, sir.
Which should be minimum 2 mm, and the plane of the tunnel,
Sir.
which should be midway in the cornea,
Yes,
so that the roof and the roof and the floor
Yes,
will
sir.
be equal.
Yes, sir.
Otherwise, it is going to leak,
Unstable.
or it can be unstable
Yes,
wound.
yes, sir.
And number second, I think the limbal incisions are better healing than the clear corneal incisions.
Yes,
It
sir.
should be preferred by the beginners. So with these message, I want to take some points from our chairperson.
Excellent presentation. We generally don't recommend even for SICS bevel down. See, bevel up is the rule. What about the your studies when the bevel is on both sides? Have you tried?
No, sir, I have not tried, but then the study it showed it's going to be a flat, sir. So the incision structure is going to be intermediate between a bevel up and bevel down, sir.
Yeah. So why I am asking this is, I generally do the side port with the MVR blade. The MVR blade is having both sides.
Yes, sir.
Isn't it? So is the MVR blade better, or we have to advise the company fellows to make same MVR blade with the bevel up? Whatever we do, they make immediately and give. This is recommended by XYZ, like that.
Yes,
So
sir.
they want the sale, isn't it? So now you study with the both one, and you take MVR blade and same ASOCT, and
Definitely,
you come to the results.
Definitely, sir.
So
we'll take
that
it.
is one thing.
Yes, sir.
What you have demonstrated is side port with keratome. Side port with keratome, I don't recommend.
Yes, sir.
Because it gives a large incision and leakage and all.
Yes, sir.
Isn't it? So side port always with MBR blade as small as possible. Your concept is excellent. Thank you.
Thank you, sir. Actually, this was done as a pilot study where we wanted to include 5 cases of SACS where we want to use the bevel down keratome for side ports. But after doing for the 2 cases which I have showed, we immediately aborted our study, sir.
Good.
Thank you, sir.
The next.
Dr. Vishnu,
Sir.
we are talking of uniplanar, biplanar, or triplanar incisions.
Sir.
Which is the better one amongst three?
Sir, definitely whichever is good in their hands.
No.
But I definitely make a biplanar, sir, at least biplanar.
For beginners, triplanar. Triplanar is better.
Sir.
So triplanar for the beginners is
Yes, sir.
better.
Yes,
Then
sir.
you can
Yes,
with
sir.
time go to the uniplanar or biplanar.
Yes, sir.
So to begin with, triplanar is better.
Yes.
Thank you very much.
Thank you very much, sir.
So our next presentation is by Dr. Ramya Metla. She will speak on beginners phaco, beginners tips to help you get started.
Sir, Dr. Ramya is sick, sir, so she is not able to make. If you permit me, I will start my next talk.
Yours is Phacoemulsification.
Yes, sir.
Phacoemulsification by Sriram.
Sir, most of this I have learned from you, sir, Dr. Ravi Kumar Reddy, sir.
Thank you.
I am thankful to APOS and AIOS for giving me this opportunity.
अरे ये वाला दो ना. सर नहीं है.
So, you want to load it there?
Yes.
So, excuse me, sir. Meanwhile, if you can ask someone to start. There is a problem here, sir. May I come there?
Yes.
Next is Sri Rama Chandramurthy, UHO Phaco-Dynamics. Next, I will request Dr. Shalini Kumari. She will speak on tips and tricks to manage a soft cataract efficiently by phacoemulsification, A to Z for beginner surgeons.
आ गया.
Good morning. Thanks for this opportunity. As we all know that soft cataract is characterized by a minimally dense endonucleus with abundant sticky soft cortical matter. And the usual chopping techniques like stop and chalk and Nagara's Phaco chop, which is appropriate for moderate to hard nuclei, it doesn't work well with the soft nuclei. The reason being, in cases with solid nuclei, it is efficient to chop using occlusion because maintaining the occlusion is relatively easy. However, it becomes technically difficult to achieve and sustain occlusion to hold a soft nucleus since the US tip tends to aspirate and perforate soft nuclear matter. So in cases with soft nuclei, what happens, we are aware that there can be a PCR. So with that fear, what happens, we embed the phaco tip very superficially, and that actually creates problem during the chopping. It often leads to an undivided bowl of the nucleus, that is the posterior plate. Also, when you are using the chopper, it actually tends to cheese wire through the nucleus during the separation. So here are few tips like CCC while going for a soft cataract should be of adequate size. There should be a good hydrodissection and hydrodelineation, and combination of different techniques work well while emulsifying the nucleus of a soft cataract. This is actually a complete video for how to do a soft cataract in a particular case, but because of the paucity of time, I'll skip and better concentrate on clips. Like this is a case scenario 1, 43-year-old, this is usual NS1, and the common scenario with the beginners, and also in my hand with some many times, I have difficulty in dividing nucleus, and whenever I hold that soft nucleus, even the part, it creates a hole while holding it. Just see a video clip. After creating a adequate size capsular axis and hydrodissection and hydrodilation, the golden rim formation is actually the end point. So while I started doing trenching, it was a very big one. Secondly, after aspirating the superficial cortical matter, while I went ahead to hold the peripheral rim for splitting into two heminuclei, it failed. Another attempt again, because whenever I was holding it, actually it was emulsifying the nuclei. So there was a hole. So after repeated attempts, this is very common scenario. So after repeated attempts, once we do sustained careful application of vacuum, then I could take out that peripheral rim, take it out of the CC margin and to the central safe zone and crack, and then proceed ahead like normal phaco cases. So in case scenario 2, like if we have a soft cataract, we can prefer hydro pop and chop. Just see a small clip. After doing hydrodissection and hydrodelineation, the popping out happened. So put viscoelastic so as to protect the endothelium, pushing the nucleus back into the bag, and then going ahead with this. So there was minimum linear phaco energy was applied, and we could do our routine phaco. See, if I am using the second instruments, it's actually not able to move also, it's so soft. At the end, like epinucleus is still left, so with the phaco probe only and with the epinuclear setting, we can aspirate it. But at times it happens that if hydrodissection is not proper or subincisional epinucleus I am not able to remove. So instead of taking risk, what I do is I switch over to bimanual one. It's safer in my hands. Instead of doing PCR, I find it far more safer. To give a better outcome is more preferable than doing taking risk in my hands. So if you are both ways of doing irrigation and aspiration, taking the epinucleus out can be practiced. Skipping to the next case, case 3, modified Bowel and Snell technique can be applied. Proper hydrodissection is a must in these cases. Why I applied the term modified is because whatever has been described classically in the literature, when I revisited my videos, I started nicely, but later on it was almost like a normal routine case. So what happens that when I tried with to take the peripheral rim, it in the first attempt didn't happen. Then again I applied sustained one, took it out from the peripheral, so from the CCC margin, and did the emulsification. Again rotated the intact one in front of the phaco probe, repeated the same procedure that way, and at this moment it tumbled. So now it becomes a usual routine one. Same thing. Coming to the next video, most of this, if we are doing it above the anterior axis CCC, then it's a supracapsular approach. Like another case, soft cataract, after doing hydrodelineation, same thing it happens. What I wanted to show is, yeah, endonucleus stand out vertically after doing the enrodissection. So we have to coat it with the viscomet so that it doesn't touch the endothelium, and holding the endonucleus with vacuum, emulsifying it with minimal phacoenergy, and chopping of the soft nuclei basically is not possible, as you all can see. Everything all similar. Another one is modified stop and chop. All soft cataract won't be very soft. So in some cases, which has got a little bit harder, we are actually lucky to do the modified stop and chop technique to crack it into a routine usual heminuclei and then the sixth case is tilt and tumble. It was a high myop case, so obviously even if the endonucleus standing vertically, I hope it doesn't touch the endonucleus. So copious amount of viscoelastic is a must so as to coat the endothelium. What happens if at this step, if it is not properly vertically standing, if I take the phacoprobe, under the influence of the jet fluid, it settles down. So what I did, with the help of the viscoelastic, actually, I put it in that position so that even if I take the phacoprobe inside, the endonucleus doesn't settle back. The next one is 30-year-old case, which has literally no hard nucleus at all. So zero amount of phacoenergy was applied, and with pure phaco aspiration, the whole nucleus was actually taken in. So zero phacoemulsification. So these are the phaco settings we apply. We all know that post surge can lead to PCR, so we have to be very careful. These are few references. All these techniques have been described. So take home message is, very soft nuclei are associated with difficulty in nuclear fragmentation. Complete division of very soft nucleus is not necessary, and the non-chopping techniques are recommended for emulsification of very soft nuclei. Thank you.
Thank you, Dr. Shalini. That was a wonderful presentation. Basically, you were trying to focus on soft cataracts. So I have two questions. One is to make this nucleus flop into the anterior chamber, you generally need to make a bigger rhexis.
Yes.
But we
yes.
did not see any IOL insertions, whether the anterior capsule was covering. If you make a small rhexis, then it will be difficult to flop
it's
it.
quite tough, sir. I had a full video, but we don't have time. So
Okay.
for 6 minutes.
And the next thing was, you have focused repeatedly on the same kind of cataracts, especially in times like recurrent uveitis, when you have to do the cataract surgery. These cataracts are very soft. In posterior polar cataract, these cataracts are very soft. In traumatic cataracts, these cataracts are very soft. So these are special situations in which you could add to this wonderful presentation that you have already done.
Sir.
Congratulations.
I had but I didn't have an idea. I'll include all posterior polar and everything. I'll include.
Yes.
Okay. Sir.
Good.
Thank you.
Very excellent presentation. But just a few tips I want to share is that hydrodelineation is very important in
Yes,
these.
sir. Otherwise, it becomes very tough.
It becomes soft cataract, give very tough time even to
Yes,
the
sir.
very experienced surgeons. And number second is that if we do a hydroprolapse or in the supracapsular phaco, we should put minimum energy or at least no energy, and that too under a good visco cover for the endothelium.
Yes.
And third, if you have slightly NS2 or like that, you can make a small trench, narrow trench. We should be narrow, we should not be wide as in mature cataracts or hypermature cataracts. So that we go for the stop and chop technique. That's all right. Next, I request to put some points.
See, for the beginners, supracapsular is the best for the beginners. Once you learn it, you can do it in the bag. So to prolapse into the out of the bag, you require delineation, not one time, many times.
Yes.
It becomes smaller.
Yes, sir.
If at all it is not coming, make a small trench. From the trench, inside out, you inject the fluid. You get the smaller nuclei, which you can prolapse. By default, either it is a soft or hard, you have to use a viscode underneath with the other, which is, we call it as soft shell technique. What people think is, oh, it is a soft cataract, there is no need for viscode.
Corneal edema happens next
Yeah.
day if you don't
So
coat it
for
with
all
cornea.
cases, use viscode underneath the other viscode. You can protect the endothelium. So the doing a soft cataract is more difficult than an N2 and N3. So that's why you learn these tricks for these things.
Sir, you're talking about the inside-out hydrodelineation?
Yes. See, sometimes it is not possible to get the delineation.
Yeah.
So you make a trench,
Then do
first a small trench, narrow trench. In the tunnel, in the trench, you inject the fluid. Definitely you get a small nucleus, which will be prolapsed.
Very small one. Central one, if you take it out, then rest
Yeah.
of the things can be managed.
Yeah.
The central.
Another thing is, you said that once you go it, again it will go into the bag.
With-
Let it go. But when you start the phaco, it will come out.
Yes.
Need not worry. Once it is separated, it is a ball inside the lens. That ball will come out when you apply a small suction. Need not worry again, oh, it has gone again to the bag. You need not worry.
So basically, the outside in hydrodelineation is usually done. But in case of posterior polar, you can do inside-out hydrodelineation by making a small trench and then injecting fluid. Because in posterior polar, we usually don't do a hydrodissection.
Inadvertently, it will go into the bag.
Yeah.
We don't do hydrodissection.
Yes, sir.
So we do a hydrodelineation inside-out.
Yes. Thank you.
Thank you very much. So next presentation is by Dr. Tadanki.
You are ready?
You are ready?
Come.
Dr. Sri Rama Chandramurthy, he will speak on
Phaco
dynamics.
Thank you, sir. Actually, this talk has been designed keeping beginners in view, sir, but I'm seeing only experts in the panel, so kindly excuse me for being too basic. I have no financial interests. Charles Kelman, 1967, he devised phacoemulsification. He's a very good jazz player. He devised the cryoprobe. He has developed he has helped in developing ECCE. He has used cryo for retinal detachments. Phacodynamics, what is phacodynamics? It's learning about two things, phacofluidics and ultrasound energy. Phacofluidics describes the factors influencing the flow of fluid into the eye, within the eye and out of the eye. Ultrasound energy transmitted by the phacoprobe is used to fragment the lens matter. So why should you know this? I hope you recognize this. Tesla Model X SUV. If you have money, you can buy this. You need not know anything about this car and you can use it comfortably, but not with the phaco machine. If you want to do phaco, you should learn everything as much as possible about the phaco machine. There are basically three types of pumps: peristaltic, venturi and diaphragmatic. Like Triveni Sangamam, you don't see Saraswati there, you see only Ganga Yamuna. So I'm doing phaco surgery for 25 years and I have never seen a diaphragmatic machine. So we are discussing only about the peristaltic and venturi. Peristaltic is a flow base. The peristaltic pump rotates, creating negative pressure and attracts the fluid from the bag, from the BSS from the bag into the eye and out of the eye. It is purely flow based. The venturi pump, the airflow is directed and it creates negative vacuum. So it is a vacuum based pump. Most of the machines we are using are mostly peristaltic based. So most of my talk will be also about peristaltic pumps. The left one is Alcon Centurion. It is a peristaltic pump. The central one is Bosch & Lomb Stellaris. It's a venturi pump. And the third one is Signature Pro, which has both the pumps, where you can use, you can switch over from venturi to peristaltic. So Phacoemulsification machine has three parts: foot pedal, handpiece and console. Foot pedal has three positions: position number 1, position number 2, position number 3. Position number 1 is irrigation, position number 2 is aspiration, and position number 3 is irrigation, aspiration and phaco. If you want, you can omit the step phaco 1 irrigation step and you can continue, keep it in a continuous irrigation mode so that your safety margin increases. So in the foot pedal position number 1, there is only irrigation. In the position number 2, you can see that there is irrigation as well as aspiration, and in the position number 3, you can see that irrigation, aspiration and ultrasound are being used. You can have other functions also in the foot pedal depending on the company you are using. You can use the foot pedal for reflux, you can use for continuous irrigation, you can change from lower grade to higher grade of Phaco, and you can change Phaco steps from Phaco 1 to Phaco 2 and epinucleus through the fit switch alone, not using the panel. The handpiece contains Phaco handpiece, and the right side one is a Phaco tip. The tip is attached to the Phaco handpiece. It can be called as a blade also. The Phaco handpiece contains a central hollow tube through which aspiration is being done. The irrigation is from outside. It enters the eye through the sleeve, and the third one is the power cord. So you can see here that the Phaco tip is covered by a sleeve. The tip has a bevel. Here it is facing upsides, and tip has an angle which is facing downside. And you can have 0 degree, 15 degree, 30 degree, 45 degree, 60 degree steps. 0 degree is good for holding. 60 degree is good for trenching. But as you cannot switch over between in the surgeries, we usually use 30 degree tip. So you can have different tips like 45 degree Kelman, and the second one is a balance 45 degrees. ABS is aspiration bypass. So we usually use 0.9 needle. If the needle is bigger, you can have more outflow. What is priming? Phaco priming includes pulling a very high vacuum and then cycling fluid through the system. These steps can be repeated a number of times to ensure that residual entrapped air is removed from the system. So priming is basically for the fluidics, and tuning is basically for the ultrasound to check whether it is ready for use or not. So now three terms. Power is the one which ultimately emulsifies the nucleus. Here you can see that 100 setting. That 100 setting is the power. One side it is 40, one side the other side is 100. So when you go to put pedal position number 3, it gives 40% of power, and when you go to the end of this thing, it gives 100% power. Power generation at the tip is dependent on the stroke length and frequency of the needle movement. Frequency is usually fixed for that particular machine, 30,000 or 35,000. Few machines have an option of changing the frequency also. Machine permits only, most of the machines permit only to alter the stroke length. That is what we get as percentage. When you keep it 100%, you are using the full power. Stroke length is the length of the needle movement. Here in the right side top, you can see that it is moving to and fro. Usually it is 0.05 to 0.10 millimeters. It is in linear Phaco. Stroke length is determined by foot pedal excursion in position number 3 during linear Phaco. Longer stroke lengths give more energy, but they are prone to generate more heat. This energy creates mechanical impact, cavitation impact, fluid and particle wave to achieve the emulsification, and as a side effect it gives heat. You can see that only stroke length can be varied and frequency cannot be varied. Frequency, most of the machines will have 35 to 45,000 cycles per second. Lower frequencies are less efficient and higher frequencies create excess heat. So 3 types of this thing. The left side one is traditional, which most of the machines use. The middle one is ellipse, where there is a to and fro and side to side movement, which is used in J&J machines. And the right one is Vosel, which is used in Alcon machines. There is only side to side movement, about 90 microns. They said that side to side movement will reduce the repulsion of the lens matter. So power you can use it continuously or in the pulse mode. In the pulse mode, there is on time and off time. During the off time, no power is delivered, so that there is the heating effect will be less. In the Phaco burst, when you go to the last, you are going from the pulse mode to the continuous mode when you are at the end of the excursion of the foot pedal. So this shows that here the power is 20 min. This is the infinity. Phaco power is showing 0, so no longitudinal Phaco. Torsional amplitude is during 20, that means it is torsion. Aspiration rate is at 30 and vacuum is 30. You can see that this torsional amplitude 20 is in a diagonal manner. That means starting it is 0, and if you go to the end, it will come to 20. That is in linear mode. And you can see that aspiration is 30 is horizontal line is there. That's once you go into the foot pedal position number 2, automatically it gives 30. That is panel control. Balance of fluid into the eye and outside the eye is known as fluidics. This helps us in giving a stable anterior chamber. This will keep the anterior chamber pressurized. This is the peristaltic pump fluid management system. The bottle height or intraocular pressure is so that the chamber remains stable and closed. Inflow, if you increase the bottle height, it will for every 15 centimeters, 11 millimeters is increased. And in the active fluids in Centurion, there is a pressure you can set at 40 millimeters or 50 millimeters of mercury. Fluid that leaves the known as either aspiration rate or aspiration flow rate or flow rate. That's the volume of fluid leaving the tube at any given time. It is measured in cc per minute. Vacuum is the holding power, the pressure difference at either end of this thing. If you increase the flow rate, the set vacuum comes fast. Here you can see that for the sculpt mode, you have less vacuum and less flow rate. And in the right side for the quadrant mode, you see that there is Phaco2, you have more power, you have more vacuum and more flow rate. Sudden transient shallowing of the AC, which may cause PC rent. The surge occurs when the outflow exceeds inflow. By using, when there is a rapid exit of fluid, there will be a surge. Higher compliant tubing leads to greater surge. So low compliance tubing is advisable. The lower one is the higher compliant tube. The upper one is the lower compliant tube. So the lower compliant tube is better to prevent surge. Venting is the main anti-collapse system. Venting can be through, when there is a negative pressure, either the machine sends air or fluid to balance the negative pressure, so that there will not be no surge. Aspiration by flow, I have already told. So you can use a bimanual irrigation aspiration or coaxial irrigation aspiration to aspirate the cortex. Happy Phacoem. It is to learn how to deliver just enough energy to break down the lens matter and aspirate, but not to damage the endothelium, and to learn to move just enough fluid through the eye and keep the antechamber very stable, so there is not a lot of surge. Sir, thank you for this opportunity, sir.
Thank you, Dr. Shriram. That was a wonderful presentation. Basically, we were talking about the physics, the mechanics of the machine in your presentation. So we'll not discuss the surgical part. For beginners, what would you recommend when they are buying a machine, to buy a peristaltic machine or a Venturi machine to begin with?
Sir, my experience is mainly with peristaltic, sir. I have a Signature Pro, but even then I use only peristaltic in that, sir. So I think peristaltic is good for beginners, sir.
That's right, because in peristaltic, the vacuum rise is slow, and in vacuum it's a very steep rise.
Yes.
So peristaltic is more forgiving than the Venturi.
Yes.
So for the beginners, it's I think a better option.
Yes. Thank you very much for your presentation.
Thank you,
Wonderful.
sir.
So as you said, instead of car, you purchase a better Phaco machine.
Yes.
And for the beginners, at least first 20-30 cases, use a continuous irrigation mode. Do you agree, Sriram?
Sir, even now I use continuous irrigation mode, sir. And
Not necessarily, but at least first 20-30 cases to get the confidence, use a continuous irrigation mode. Afterwards, you will get, oh, I am wasting my fluid.
Sir, one more point is once we're making a trench, that we should know the plane, how to make a trench. And we should apply ultrasound in the forward mode only, not continuously.
We are not discussing the surgical part. This is only the physics.
Physics.
thank you, sir.
Thank you so much. We'd like to call the next speaker now, Dr. Tardanki Ramakrishna.
Yeah.
Dr. Tardanki will be speaking on how to do phaco in hard cataracts, the fundamentals.
Good morning. Now I'm going to talk about top pearls in the management of hard cataract. Hard cataracts are difficult even for the most accomplished surgeons because the lens becomes thick, bulky, it gets compacted, it stretches the capsule, and the capsule gets thinned out over a period of time. And because of the thickness of the cataract, the anterior chamber also becomes compromised. Because of the weight of the cataract, the zonions also become weak. So you have a very difficult case to handle on the particular day. So what is very difficult for one person may not be that hard for an experienced surgeon. So before we take up a case for surgery, one should do a thorough slit lamp examination of the patients. So we should look for corneal opacities, corneal dystrophies, endothelial disorders, and one should take a note about the anterior chamber depth, a presence of pseudoexfoliation or a pigment dispersion which might indicate a previous inflammation. One should also take a note about the size of the pupil because a smaller pupil adds to the difficulty of the surgery, and one should also take a note about the presence of any posterior polar cataract. So while examining the retina also, one should also look for old vascular obstructions, a glaucoma, a old RD or any other factor which might indicate a poor vision in the post-operative period, and one should always caution the patient about that. And one should also take a drug history also for a possible IFIS because presence of IS will complicate the surgery even more. So one should inquire whether the patient is on tamsulosin, benzodiazepines or antipsychotic drugs. And one should also counsel the patient about a prolonged intraoperative period, a prolonged recovery time, and a possible extended use of medication in the postoperative period. So unilateral cataract in one eye with little or no cataract in the other eye should always alert the surgeon about a possible old trauma or inflammation. So preoperative examination, if the visibility is poor, then one should always do an ultrasound B scan to rule out any vitreous hemorrhage or any choroidal masses or any advanced cupping. So all these things one should look for. And one should never give a positive counseling to the patient if the retina is not visualized. So then coming to the biometry, if it is possible, one should always do an optical biometry. But this is also quite difficult because point number one is that the patient cannot fix it on the target, and number two, light cannot traverse through the dense cataract. SSOCT based biometers like IOL 700 can give a good biometry even in a very dense cataract, but if you cannot do this, one should always revert back to ultrasound A scan. The choice of the surgery depends upon the experience of the surgeon, and if the surgeon is experienced enough, phaco is the choice, but for a less experienced surgeon, it's always better to do SICS or phaco with a scleral tunnel, because one can always convert to SICS in case the surgery is not going or proceeding the way you wanted to go. So I'm going to enumerate the top 10 pearls in managing a hard cataract, which I'm going to elaborate in the coming slides. So the first pearl is to make an anterior entry while you're making the tunnel. So because the density of the cataract, because the anterior chamber is compromised, these patients have a tendency for the iris to prolapse. So if you try to reposit the iris with some blunt instrument or something repeatedly, the pupil might become smaller. It adds to difficulty during the surgery, so one should always make an anterior entry. So this risk of iris prolapse becomes more when you're doing the phacoemulsification because of the egress of the fluid through the ports. So after making the ports, then one has to stain the anterior capsule, and one should always stain the anterior capsule because the red reflex is not really good. So this gives a better visualization, gives a better color contrast, and making the rexis becomes easier. So this avoids injury to the anterior capsule while doing the chopping, while removing the nuclear fragments, and it also helps in accurate placement of the instrument while doing a horizontal chop. But my suggestion is, because in these patients you don't have much of a cortex and there's absolutely no place between the capsule and the nucleus, it's better we avoid a horizontal chop. I say horizontal chop is contraindicated. So without stain, even a successful rexis is difficult to see. So once we stain the anterior capsule, then we reform the anterior chamber with viscoelastic. So because you have a very dense cataract, you have a long operating time, you will be using more amount of energy to emulsify the nucleus. So one should always use heaps of viscoelastic. So I do my variation of soft technique in which I inject a coercive dispersive viscoelastic first, and beneath that I inject HPMC, which pushes the coercive dispersive up towards the endothelium and protects that. So plain coercive like sodium hyaluronate doesn't really help because it gets easily washed away. So while doing the surgery also, one should always interrupt the surgery in between to replenish the anterior chamber with OVD whenever required. So after the anterior chamber is reformed with the OVD, then one has to make a rexis. The sizing of the rexis is very important, and one should always aim for 5.5 to 6 millimeter rexis. So if you have a small rexis, then chopping of the nucleus or removal of the nuclear fragments is difficult, and one might accidentally injure the anterior capsule also. And if you make a large rexis, probably you will have difficulty getting a adequate overlap on the optic. So it's always better to use a nitrata forceps to have a better control while doing the rexis. So after the rexis has been done, one should ensure a mobile nucleus. So one should always keep in mind, as I was telling you previously, there is no cortex here, very little cortex here. There is always a chance of a capsular lenticular block. So you try to do a aggressive hydrodissection, then probably you might break the posterior capsule and nucleus might drop into the vitreous. So what happens in capsular lenticular block? Because there is no cortex, if you do a aggressive hydrodissection, the fluid will push the nucleus up and seals the rexis margin. So the further amount of fluid which you inject is going to break the capsule and finds its way into the vitreous. So after you do, how you do the hydrodissection? So you have to inject a small quantity of fluid in multiple quadrants and frequently tapping the nucleus below by burping out the excess amount of fluid in the posterior chamber. So after we do the hydrodissection, then one should always rotate and make sure that the nucleus is mobile in the capsule bag, whether it's completely broken off all the additions. So a non-rotating nucleus can be difficult. It can cause stress on the zones. One might end up with a zonal dialysis also. So before we start the phacoemulsification, one should always expose the phaco tip more than usual. And there's a time we start doing the phacoemulsification. This is the most important pearl I want to make. So the depth of the trench is more important than the length of the trench. In some videos, I see some surgeons making a huge trench from equator to equator, and this is absolutely not essential. You just need to make about 3 to 3.5 millimeter trench at the center. So you're doing two things there. The one thing is you're weakening the posterior plate, and you're getting a good amount of the meat of the nucleus to get an adequate purchase while doing the chopping of the nucleus. So whether to do a horizontal chop or the vertical chop is purely a surgeon's choice, but it's always better to avoid horizontal chop. So once we make two heminuclei, then it's time to subdivide the nucleus into multiple quadrants. It's like eating a slice of cake instead of eating the whole cake as a whole. While doing the while subdividing the nucleus, one should remember that these nuclei are thick and leathery, and it doesn't crack very easily, don't get adequate separation. This is because the epinucleus gets compacted with the endonucleus. This epinucleus runs on the posterior surface like strands, gets thickened and hardened over a period of time, and this is what gives the leathery nature for this cataract. So even after you make it into multiple fragments, what will happen is that these fragments are attached to the center like a flower petal. So it's very difficult to get an adequate separation. So what I do is I have my own technique, which I call it as a push-up and strip technique, where I push the fragments towards the periphery. So the central part comes up, it's away from the posterior capsule, then I hit it away with the phaco handpiece. So then I can always emulsify the nuclear fragments. So whatever technique you use, whether it's a divide and conquer or you do a stop and chop, the resultant fragment is always larger than the lesser grade cataracts. So if you have a larger fragment, the fragment gets deflected away from the phaco handpiece. So it's always better to have a smaller fragment. So take some time and make it into more number of fragments instead of struggling with a bigger fragment. So one should always create a visco wall. So visco creates an artificial epinucleus, gives some space for you, it pushes the posterior capsule down, it coats the endothelium and protects it. So as long as you have the nucleus in the capsular bag, it holds the capsular bag in place. So while removing the nuclear fragments, what will happen is the posterior capsule comes towards the phaco tip whenever you have a post-occlusion surge, and it is a great risk of injury with the phaco handpiece. So one should always use huge amounts of viscoelastic. So this is the power modulation. This is one more very, very important point I would like to make. So power modulation is very important. So one has to use a high vacuum and a moderate power. The usage of high vacuum decreases the need for higher amount of phaco power. So if some time is there, maybe I would like to elaborate. Recently I was doing a bit of a study, like I was checking, my machine has got a dual linear control also. So dual linear, I go up to 330 millimeters. When I went up to 330, even in a grade 5 cataract, I could emulsify the nucleus as 25 to 30% of the phaco power. But when I am just going in the linear mode at 200 millimeters of mercury, I could emulsify at 55 to 60% power. So it's always better to use high vacuum while emulsifying the nuclear fragments. So one should always emulsify in the iris plane or below that, but never above the iris plane in the anterior chamber, because you might fry up the corneal endothelium. So one should always use a huge amount of viscoelastic. So when to stop the surgery? Whenever you see a smoke kind of thing near the phaco tip, the lens plume, which we call, it indicates a block tip. It's because of the big nuclear fragment going and blocking the phaco tip. This will raise the temperature in the handpiece and might cause a wound burn. Even a high viscosity OVD can cause clogging of the phaco tip and can cause a wound burn. So wound burns should always suture, because there's a high risk of astigmatism. So one should always be prepared to convert to SICS whenever you feel that the surgery is not going the way you wanted to go. So one can do either a scleral tunnel in the same plane, in the same area at a deeper plane, or one can change from temporal to superior or vice versa. So what are all the dangerous signs here? So if you feel that the phaco is inefficient, it might be because of the vitreous in the antechamber, you see the nucleus is tilting, or the PC starts suddenly looking very, very clear. All these things indicate the PC rupture. So points to remember, so before we start off the surgery, or incisional burns, the capsular integral block, a potential endothelial loss due to high energy and a particular turbulence, PCR and weak zonules. So the two most important pearls which I want to again repeat here, number one is the depth of the trench is more important than the length of the trench, and a power modulation. Use a high vacuum and a moderate amount of power instead of using a high amount of power and frying the cornea. Thank you very much.
Thank you, Dr. Ramakrishnan. That was a wonderful presentation.
Thank you, sir.
Each and every point you have covered.
Thank you.
That was wonderful. I don't know if there are any beginners over here. They're all experts sitting over here. But if there are any beginners, I think you should take a copy of his presentation to see all the points that he has already covered. Anybody has to say anything?
A very excellent presentation for the, especially for the beginners.
Thank you.
But I think the depth of the tunnel, the width of the tunnel is also important in the
Yeah.
hard cataract, because otherwise it leads to the blockage of the sleeve. So the width should be also, width of the tunnel is also important. Number second, the learning of the chopping manuals in hard cataract is very important, because in soft cataracts you need not to chop the things, but in hard cataract it's very important to chop properly.
Yeah. Right.
Thank you.
See, for the beginners, not for the experts, the black cataract, white cornea is the joke. If you operate a black cataract, you land in a white cornea. So to avoid that, your power should be away from the cornea, in which good old method of 4 quadrant. Make a quadrant, trench, horizontal trench. You got 4 pieces. Your aim is 8 pieces. Make each quadrant into 2 pieces. You get 8 pieces. All are within the bag. Afterwards, you use high-end visco even from the beginning, and you do quadrant by quadrant. You get excellent results. This is for the beginners. Experts, whatever you are comfortable, you do it. Do 4 quadrant, make into 8 quadrants, 1 quadrant by 1 quadrant, take your own time. Your own time will causes cooling of the endothelium, cooling of your wound. But attempt these hard cataracts with high-end missions only. With low-end missions, attempt SICS.
That's true. That's true.
One-
Okay, go ahead. So the earlier dictum was that you go on making the trench so much so that you just about begin to see the red glow,
Yeah.
which is now not so much true. Now we make go halfway, and then with high vacuum machines that we have, we make a chop and we crack the nucleus. So high vacuum and a hold is very good, important.
The thing is, no, you really don't have to see that red reflex, so you don't have to go so deep.
Yes.
So if you can trench the nucleus at least 60 to 70%, I think you can comfortably crack the cataract.
Correct.
I was telling you, know, like I was seeing one video where the surgeon was trenching almost 50 to 60 times. It's unnecessarily, you're releasing so much amount of energy inside the eye, and probably you don't know, you're literally frying the endothelium there. No, it's really not really essential. So just make a small trench, you know, that will really give a good, nice crack.
Nice. So one more thing I feel is that the last piece,
Yeah, yeah.
that is a problem for the beginners, and even most of the surgeons have got
So the last piece, two things are there. So one thing is the post-occlusion surge, and this thing has got the sharp edges. You know, so probably if it tumbles, it might go and break the posterior capsule. So frankly, it never happened to me, but theoretically it can always happen.
But there are some points there we can put an IOL scaffold technique for the beginners.
Yeah.
So the IOL can be put before removing the last piece.
Yeah.
So one is that, and or you can put a visco down,
Visco is
down the piece.
For
And
last piece, use visco.
No,
or number third is that you can put some instrument like iris repository or anything below the phaco tip, so that the PC does not come up.
so my suggestion is take a minute or more, inject more amount of viscoelastic, than to have a very unsatisfied, dissatisfied patient for weeks or months together in the post-operative period. So I think using loads of visco, I think, is the key for a successful surgery in a hard cataract.
Especially once you are doing a phaco, in between also you have to use the
Yeah,
visco.
yeah, yeah.
That's
Correct,
more
correct,
important
correct,
to coat
correct.
it.
Thank you very much. We'll move on to the next topic by Dr. Tripura Velagupadi, and she'll be speaking on phacoemulsification.
Excuse me, sir, there is one question from.
Please,
Please, Shirin.
Sir, in my college, I have got a very basic machine, APA only. So, and I do hard cataracts with them. So, we apply burst mode. So, most of the barring few occasions, cornea is okay.
Probably you
So-
are expert.
No, I'm saying give some suggestion. You said
Yes,
only
yes.
with the high-end machine. We don't have high-end machine. It means I won't be able to do hard cataract. But I do it with the burst.
If it is a black cataract, I suggest
no,
yes.
black cataract I don't. Brown cataracts I do regularly with the burst mode. It works.
What
well.
about your results?
It works well.
Huh?
It works well.
It wo- it
barring
will
few
Works well.
cases.
Have you studied the endothelium?
No, sir, I don't have the more to study that.
Yeah,
Cornea
please
is
study the
clear.
endothelium, at least 20 cases of your brown cataract.
Cornea is clear. I don't
No,
have
no,
anything else.
not the, you have to follow them for 15 years.
Okay.
You are not totally wrong. Burst mode is a lesser phaco energy and much safer to do. So burst mode is a good idea.
Repeated use of viscoelastics, what he
With
said, that I
repeated,
do it.
yes.
So that
But I
High
think
molecular
the burst mode or pulse mode can be used for a direct job.
Direct chop and for emulsifying the pieces also.
I
you
mean
can
that
use burst
once
mode
you
so that
use the
phaco
burst
power
or
is
pulse
less.
mode, that will, with a direct job, that will decrease the energy level.
Yes. Yes. So Dr. Tripura will be speaking on phacoemulsification in hypermature cataract.
Yeah. Good morning, everyone. On the on-site, I want to thank IPOS and AIOS for giving me this opportunity. Today, I'm here to talk about the phacoemulsification in hypermature cataract. I'm working as a consultant at CFS Vijayawada. Hypermature cataracts, as we all know, are challenging at numerous steps of phacoemulsification surgery. These can be broadly classified into Morgagnian type and a sclerotic type. Morgagnian type is nothing but the cortex undergoes autoliquefaction and turns uniformly milky white, and the nucleus loses its support and settles to the bottom. The sclerotic type is the same, but it has calcific deposits over the lens capsule, and sometimes it may present along with iridodonosis and phacodonosis. Coming to the surgical steps, for a beginner, it's always better to give a peribulbar block to start up the surgery and to give a pre-operative mannitol. Once you give the peribulbar block, it's mandatory you soften the eyeball by using a pinky and giving a digital massage. The incision, it's better you give a limbal incision rather than giving a clear corneal incision. To start with, you can do only a side port or a partially opened main port so that the AC doesn't collapse as such. Trypan blue staining is a must in cases of hypermature cataract as it doesn't have any red glow and it helps us for better visualization. As such, the surgery is as easy as that except for the capsular rhexis. Capsular rhexis is the major part of the surgery. So for doing a good capsular rhexis, viscoelastics play a very important role. Tri-soft shell technique can be used in which we inject viscose dispersive OVD, which is nothing but a viscoat, injected around 25% on the anterior capsule and then followed by an Helon 5 which is injected underneath. So anterior chamber should always be formed. So there are many types of capsular rhexis which have been described by many other many procedures. The most commonly used is the two-stage capsular rhexis. Coming to the needle decompression, in this we put just a 25 gauge or a 26 gauge needle into the anterior chamber through the main incision, and then we just puncture the anterior capsule and remove the liquefied cortex in around 0.1 to 0.2 ml at one go. This is nothing but a two-stage rhexis which is popularly used, and it is first described by Gimbel in 1993. In this, the initiation of the rhexis is always better to do with an cystotome, and it should be a C-shaped flap so that it doesn't cause an Argentinian flag sign, and then followed by the completion of the mini rhexis with the help of the rhexis forceps, micro rhexis forceps or the Atrata forceps, whichever you're comfortable with. And then we have to aspirate the fluid with an IA cannula or a Simcoe cannula or with a hydro cannula of your choice. And then once the mini rhexis is over, it is as usual as the same rhexis in which we do. We can give a small nick with a micro rhexis scissor or a Navanas, and then we can just extend the rhexis to the required adequate size of around 5 to 6 mm, which is very helpful for doing the phaco. In this, usually 90 to 95% of the cases will achieve the capsular rhexis. Once the capsular rhexis is achieved in hypermature cataract, it is as similar as any other surgery which we do in our day-to-day practice. This is nothing but a flax, which is femtolaser assisted cataract surgery. This gives promising results, but the only constraint here is because it has an liquefied cortex, sometimes it may interfere in the subsequent laser pulses, and then it may cause gaps. So it's better once you enter into the anterior chamber, you just see to that with the forceps that the total capsule is freed with the laser pulses. Next is phacocapsulotomy. It is described by Mohan Rajan sir. It is nothing but the phaco probe is injected into the anterior chamber. It is put over the anterior capsule, will give the ultrasound energy, will puncture the capsule and also remove the liquefied cortex at one go. Some surgeons also do an NDAG capsulotomy in which we'll do an laser shot in the OPD and then go ahead with the surgery at the OR. So coming to the nucleus management, once the capsular rhexis is over, the nucleus management is as same as the previous speakers have spoken about the hard cataracts. But here I want to just tell you 2-3 points, because it's an empty bag, it doesn't have an posterior capsular support. It's always better we have to think about the PC. So it's better you'll do a vertical chop. The vertical chop, after doing a vertical chop, you can do it in a burst mode because it causes less of damage to the corneal endothelium. Here I have done a small trench in which, and then I have buried totally the phaco tip and then started separating it. It's better you rotate it totally 180 degrees, make it into 2 halves, and then go and make it into 3 pieces, that is at least 8 pieces, and then remove each piece by piece so that the endothelium will not be damaged. When coming to the last piece, it's better you go to the sculpt mode because it doesn't have much of vacuum and it doesn't cause much of surge, and the risk of PCR also get reduced. And once the nucleus has been, once you embed the dip, it's better you have to see that the posterior pole has been totally separated, in which we have to occlude the probe totally, see to it the posterior plate is totally separated, and it becomes as piece by piece. And once the pieces have been done, the posterior plate should be captured and then start from behind. Once the nucleus has been taken care, the IOL of your choice can be placed in hypermature cataracts. Coming to the surgical complications, the most dreaded complication is the Argentinian flag sign, which we all face once in a way. Maybe it is less than 1%, but still it is really a nightmare for us. There is one case where we got, so we have gone ahead and just extended the rexus with the rexus forceps, and then we have circularized the rexus, and then because being a soft cataract, we have done the new phacoemulsification and implanted an IOL in the sulcus. We have to place a 3-piece IOL in front of the back. However, the haptic should be placed 90 degrees to the direction of the anterior capsular tear. So posterior capsular rupture, it's always difficult to place an IOL in posterior capsular ruptures, but still when you have a fragment, nuclear fragment remaining, when you get a posterior capsular rupture, it's better you use an IOL scaffold technique, in which you'll put a 3-piece IOL inside the AC, and then you make the nucleus piece sit over the IOL, so that the IOL acts as an tamponade and the PCR will not extend any further. So here we put the phaco probe and then emulsify the nucleus. Depending upon the support of the anterior capsule, you can go ahead and put it in the sulcus, or you can go ahead and put it in a scleral fixating or a glued IOLs as such. So take home points, liberal use of viscoelastic is a major step for any hard cataracts for that case, but in this case capsular is much more important. For that, the liberal use of viscoelastic is a must. Informed GVP consent for the attender and the patient, and the risk of not putting an IOL and taking up for a secondary IOL should also be explained to the patient and the attender as well. Capsular rexus is the major part. Once the capsular rexus is achieved, it is as easy as a cakewalk, which can be done by any of us. Intact posterior capsule and preserving the corneal endothelium without any damage is utmost important, and you should have a backup of iris claw lenses and also a 3-piece IOL in your armamentarium. Don't hesitate to ask for a help if you really have a retina consultant, if you get a PCR or a zonular dialysis. Convert if needed. Thank you so much for your patient listening.
Nice presentation. As far as the femto is concerned, you know that there are adjustments for the capsulotomy. You know that?
Is there?
In a femtorexis, you can modulate the energy parameters for the things.
Yes.
For this, what I put is supra fast. What is the duration of the rexis in the normal rexis?
But in case of femto, sir?
In case of femto. Duration of the laser.
I don't have much of idea, sir, because I
Yeah, normal duration is 1 second. Whereas special supra fast, it is 40% of that, 40% of that, where for the intumescent cataracts, we put that. The only thing is it is fast and the vertical height is more than the normal. So it definitely makes a cut even in the intumescent cataracts. But as you said, stain. After that, stain, whether it is separated or not, if at all not separated, it is easy to separate because already postal stamps are there.
Yes, sir.
So it is much comfortable with femto in these cases. The other thing is, you made a small rexis, again scissor, again large rexis. For that, what I give is, make a small rexis, don't detach that flap. Keep that flap at the end. So with that flap, you make a spiral.
Yes, spiral rexus.
Easy. Rather than again introducing the scissor, the moment you introduce the scissor, that itself may run away sometimes. if you are vertical. If you are tangential, it is okay.
Yes.
So that also time taking and more skill than leaving a spiral. You do the spiral whatever you want and be on the lesser side, complete your course. After implanting, again you do the rexis.
Yes, sir. Yes.
Nice presentation.
Thank you so much.
One or 2 points I want to make is that the rexis is a problem especially in Morgagnian cataracts. So one has to be well versed with the rexis by forceps than by needle rexis. So the problem with the forceps is that you press the incision posteriorly and there is a leakage of the visco, and that leads to shallow AC and that can lead to the runoff of the rexis. So the beginner should be then well versed with the use of forceps in such situations.
Yes.
Number second is that once you are having an Argentinian flag sign, for the beginners it's better to convert it to the SICS.
True.
Number second, if you want to continue with the phaco, then you have to pull the nucleus out of the bag and do a supracapsular phaco.
So wonderful presentation, Dr. Tripura.
Thank you, sir.
I have one very basic question, and my basic question is, to begin with, you did the hypermature cataract surgery because the intraocular pressure was normal. But in the beginning slide, you said you want to give mannitol. Now, if we want to understand the physics of the hypermature cataract, it's the intralenticular pressure which is high. It's not the intraocular pressure.
Ocular pressure. Yes, sir.
Now, how does mannitol help in reducing the intralenticular pressure?
As
If it is associated with glaucoma, you are right.
yes.
If
There
the
is
intraocular pressure is normal, there is no role of mannitol.
Usually we'll not give any mannitol preoperatively, sir. Usually we'll just give an topical anti-glaucoma medication before, just a drop of Dorzox before I take to the surgery OR. But in case when we have an borderline IOP of around 23 or 24, then I prefer giving a preoperative mannitol half an hour before we take up for the surgery and then go ahead with the surgery. It is just that it reduces the overall intraocular pressure, so that it doesn't help us in any the lenticular pressure as such, but still overall the surgery becomes easier with ease. Sometimes we end up with a floppy iris in these cases, which we really don't know. For all those, it may help. That's what that is.
But basic physics of
there is no role.
There is no role of intralenticular pressure is not reduced with any mannitol.
So another important thing is don't depend on simple methyl cellulose. Keep ready the Helon for this rexis.
Yes.
Inject Helon and start the rexis.
Thank you very much. The next presentation is by Dr. V. Meenakshi. She will speak on management of post-cataract surgery astigmatism.
Who are the other speakers who are left? Anybody else after?
She is the last speaker.
She is the last. Dr. Rajneel is not there? Dr. Ramya?
Good morning, everyone. I am Dr. Meenakshi from Government Regional Hospital, Visakhapatnam. And with continuous advances in cataract surgery, patients have higher expectations of surgical and visual outcomes. Approximately 40% of cataract surgery patients have one or more diopters of preoperative keratometric astigmatism. Astigmatism has considerable impact on quality of vision and is affected by surgical technique, type, and size of incision. Hence, the importance of correction of the astigmatism during surgery. And refractive astigmatism is a combination of corneal and lenticular astigmatism. Lenticular astigmatism is usually eliminated during cataract surgery. And thus, to manage astigmatism with cataract surgery, surgeon has to address the total corneal astigmatism. Total corneal astigmatism comprises both anterior and posterior corneal astigmatism. And with increasing age, anterior corneal astigmatism tends to drift from with the rule to against rule astigmatism. In contrast, posterior corneal astigmatism does not tend to change with age. And anterior corneal astigmatism can be accurately measured by a variety of methods like the keratometry, topography, and OCT, etc. And these are the sources of postoperative cataract astigmatism.
The slide is not moving here.
I mean, here it is moving.
It's not moving here. We are still on slide 1. Audio visual? Ah, no.
Thorough preoperative ophthalmological examination is mandatory, and note the refractive status and amount of astigmatism, location of axis. And surgically induced astigmatism is we need 3 primary sets of data required: preoperative, postoperative keratometry, and location of corneal incision. And in addition to the anterior keratometry, posterior corneal keratometrics are also very important. And from these data, using vector math, surgically induced astigmatism of our incision or the incision can be calculated. So this is a surgically induced astigmatism calculator. So we have to enter the, we'll get the incision size and location and depth of the incision. And coming to the various techniques for astigmatism correction, the wound modification or tailoring and incisional astigmatic surgery. It can be astigmatic keratotomy or limbal relaxing incisions, and toric intraocular lens, and multifocal with toric IOL, and multifocal LRI, and secondary laser visual corrections, and femtosecond relaxing incisions. And coming to the wound modification and tailoring, here is a Paul S. Cock incisional funnel, and the incisions are made if within this tunnel, usually astigmatism is neutral. And these are the various types of incisions. And in the first and second picture, you can see the incisions are extended outside the funnel, and they are induced significant astigmatism. In the third instance, the frown incision within the tunnel minimizes the astigmatism. And an incision relaxes meridian, which is vertical to the incision, and shorter and posterior incisions are lesser astigmatism, and longer anterior incisions lead to greater astigmatism. And superior incisions produce more astigmatism, and temporal incisions cause lesser astigmatism. And plan of incision is on the steeper meridian. So, and pre-existing againstual astigmatism, if it is there, temporal section is preferred, and oblique astigmatism is difficult to cite and require additional astigmatic corrections. And these are the various amount of astigmatism with the scleral tunnel incisions and clear corneal tunnel. And out of these, the temporal clear corneal incision of 3 millimeters usually produces lesser astigmatism. And these are the various, depending upon the preoperative astigmatism, we can alter the size and shape of the incision, length of the incision, so that to minimize the astigmatism. And there are various effects of the sutures are also there. If loose sutures will increase againstual astigmatism, tight sutures steepen and zone meridian increased with the rule astigmatism, and vertical and horizontal sutures, they also change the amount of astigmatism, and non-absorbable suture cause lesser againstual astigmatism. And incisional second variety is the incisional astigmatic surgery. This the astigmatic keratotomy is one thing, and here the straight or arcuate incisions with the diamond blade incision 600 microns depth are given, and in the 8 millimeter optical zone, and 1 2 millimeter incision of 30 degrees arc will induce 1 diopter, and 2 millimeter incision cause change 2 diopters of astigmatism. And timing is usually this is done post-operatively once the refraction is stabilized, and the indications is in moderate to high levels of astigmatism, and the amount of astigmatism calculation is available with the nomograms. And coming to the astigmatic keratotomy is done with the number of incisions also can be altered, and single or double or paired using a diamond blade. And coming to the complications, micro and macro perforations, keratitis, endophthalmitis, irregular astigmatism, and other things. And coming to the LRS and PCRIs, here this can be done along with at the time of cataract surgery. Usually corrects 0.5 diopters to 3 diopters and placed at the limbus, and usually cause lesser visual disturbances. This is the nomogram showing the amount of astigmatism with the number of incision and length of the incisions. And all the preoperative evaluation is done thoroughly, and using the nomograms we will know the amount of incision and length of the incision and depth of the incision also. And this is the variant for LRI is used. And coming to the LRS, the length and number of incisions are decided according to the nomogram. PCRS is just inside the limbal vessels, and 600 micron adjustable diamond knife is used to create LRIs. Depth is usually up to 90%, it can be used. And This is the addressing the corneal astigmatism. So before surgery, there is one diopter of visceral astigmatism, and it has increased with phacoincision, but it is compensated with the LRIs to the no astigmatism. And in this, the corneal coupling effect is shown, and with the corneal incisions on either side, the spherical equal, it has the astigmatism has reduced, and larger incision causes more flattening, and smaller incision causes lesser flattening, and the central incisions are more flattening than the peripheral incisions, and deeper cuts will give are more flattening than the superficial cuts. And coming to the LRS, the advantages, it is easy and minimal instruments at the time of cataract surgery, it can be done. And coming to the toric intraocular lenses, can correct up to 6 diopters of astigmatism, and toric IOL calculators are available to correct the estimate the amount of astigmatism. Special investigations are necessary to confirm the axis and confirm the keratometric readings, and these are the various investigations for keratometry, and accuracy of toric IOL calculator is used for the calculation of the IOL power and inputs. These are all the inputs, and this is the output. We get the model of toric IOL and optimal axis orientation in the bag and expected residual astigmatism and incision location. And before there is axis marking can be done either manually or automated method. These are the various manual methods for astigmatic in marking, and the automated method is a variant image guiding system can be used intraoperatively, and uses optical refractive analysis also for intraoperative guidance. And in here surgery, during surgery there are certain tips are very important. 5 to 5 millimeters of rexis with the edges should cover the IOL margin, and marks cohesive viscoelastics are preferred, and after the IOL alignment, OVD should be completely removed for final alignment, and tap IOL down to intracapsular bag to seat the lens into the posterior capsule. And these are the various steps, and advantages is corrects up to 6 diopters. Disadvantages is may cause rotation and cannot correct irregular astigmatism. The complications, the contraindications are irregular astigmatism, jonular instability, and posterior capsular dehiscence, and poor pupillary dilatation, chronic dry eye. Here 1 degree alignment usually reduces correction of 3%, and 30% error usually completely the astigmatism correction is completely lost. And management is realigning and repositioning of the lens can be done within 2 weeks after surgery. And coming to finally, what method is to choose is low degrees of astigmatism. You can go for PCRAs and toric IOL up to 6 diopters, and we can combine both in case of high degrees of astigmatism, and multifocal toric IOL if, both for near and distant vision, and also multifocal plus LRS can be done. And for the residual astigmatism, the secondary laser vision corrections or LASIK can be done, and femtosecond relaxing incisions can also be done with the phaco. So thank you very much.
Thank you, ma'am. For paucity of time, we will not be able to take the discussion part. I would like to invite respected Dr. T.P. Lahane sir, Dr. respected Nausher Shroff sir, Dr. Tushar Agarwal, Dr. Ragini Parak ma'am, Dr. M. Vanati, and Dr. Anaga Harur for the next session, which is cataract surgery and beyond. Thank you very much to all the speakers and the panelists on the chair.